Starting. All attendees are in listen-only mode.
Good evening, this is Dr. McSherry. It is 9:12 p.m. on June 12, 2014. Tonight is our last webinar before the examination, and I am looking forward to going through this exam, our last and final exam with everybody prior to the exam. That's going to be on June 30th. And I'm looking forward to seeing a lot of you in Key West this weekend. We have our first must-pass study camp, and then hopefully I'll see a lot of you too also in Chicago. So what we're going to do is going to go ahead and just go through this exam instead of taking it tonight, not waste any time. And I see I have a volunteer tonight. And hi, Scarza. Thank you so much for volunteering. I'm sorry about the dogs are a little unruly tonight because they haven't been fed yet, so they're just kind of like jumping all over me and stuff. So I had to calm them down for a second. Okay, let's get Dr. Garza here. Hi, how are you?
I'm doing well. How are you?
Good, 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 good. You getting excited about taking your exam and getting it over with?
I don't know if excited is the word, but yes, I'm excited about it being done, for sure.
Yeah, I know, right? And then you can have a good time. But the even better portion is going in there, taking that exam, and knowing the fact that you passed it, and then you can go on a vacation and enjoy yourselves, and then you get that pass letter. Oh, by the way, last year, you know what? I was going through my notes from last year. Guess when they gave the results from the test last year? September 1st. Isn't that crazy? They gave the results September 1st. So I don't know if that's going to happen again this year. Who knows? But I do recommend everybody start looking at their ABOG on the ABOG website. Start checking like maybe the first week of August and maybe check every other day or something to see when the results are posted. I have a funny feeling they're probably going to be posted the second week of August, but I think last year, because of all the stuff that happened with another board review company and the issue that a lot of the test questions had leaked out, I think there were they watched the exam a little bit closer last year. So I don't know. So be it. What are you going to do? Stuff happens. It is what it is, right? So anyway. Oh, it was August. Oh, somebody said it was August 26th that the results came out. Oh, I remember too well. Okay. All right. That's fine. Okay, so August 26th it came out last year. God, why did I think it was September 1st? All right. Not a problem with that. Okay, well, we'll go ahead and get started here. Okay, number one, go ahead.
Okay, which of the following procedures is optimal for a patient with urinary stress incontinence secondary to intrinsic sphincter deficiency? A, paravaginal repair, B, Burch procedure, C, Marshall, Marchetti, and Krantz retropubic urethropexy, D, sling procedure, or E, oxybutynin. So I believe the answer is D, the sling.
Okay, good. And tell me what intrinsic sphincter deficiency is. I mean, what is that condition?
I don't know that I can articulate it very well, but just that the sphincter,
do the best you can. Do the best you
can. The sphincter that allows or that maintains urinary continence is like the actual muscle fibers are attenuated, like the smooth muscle fibers that make up the sphincter.
Yeah.
Are not working properly.
Right, and so if why is the treatment a sling then?
Because essentially you're creating a kink on purpose so that it kind of creates some back pressure in the urethra and then can prevent urine from just leaking straight out.
Yeah, I can see that.
I don't know if that makes
Yeah.
Probably not detailed enough, but
yeah.
So you put it goes at the UV angle, right? So it corrects. I'm sorry, it goes at the mid urethra, right? So it corrects the area where there would be an increase in pressure normally if the sphincter were intact, and that allows you to maintain continence when you feel the urge like your bladder is full, but you can't go to the bathroom yet. So since the sling is there, it creates an increase in like pressure that has to be overcome in order for the urine to come out.
You know, that's a reasonable answer. And I think it is. Now, there were older treatments for intrinsic sphincter deficiency where they used to give them bulking agents at the neck of the urethra, and they found that that wasn't, people weren't having much success with that. So, you know, they
Like
started
Botox?
not Botox, Durasphere.
Or Durasphere. Okay.
Yeah. Yeah, and then also too, remember, intrinsic sphincter deficiency is a little bit different than hypermobility of the urethra. Hypermobility of the urethra, intrinsic sphincter deficiency is a little bit of like, it's like a mixed incontinence type picture, whereas hypermobility of the urethra is strictly an anatomical problem, where if you do a cough stress test or do a Q-tip test, the Q-tip goes over 30 degrees when the patient coughs. Mm-hmm. So collagen injections. Well, collagen injections, they weren't. They weren't using collagen. Something called Durasphere, and it was some kind of particle that they were injecting around. You were doing it cystoscopically, and you were injecting it around the sphincter to see if that would, to try to bulk it up a little bit to help with the closure pressure. So they found like patients were failing that procedure. Oh yeah, copolite injections. Yeah, I think that's right. It's copolite. Yeah, copolite injections. I think that's correct. If you want to Google it real quick, yeah, I think that's correct. Yeah, something like that.
And the Botox injections, if you have like overactive bladder, then they do that to paralyze the muscle. I've seen like a urologist do that we used to scrub with.
Yeah, I guess that's probably
I don't know if they still do
use
it
for it. You could probably do, yeah, Botox, I guess, for that. Yeah, I guess so, for dyssynergia.
Overactive.
Mm-hmm. Yeah, yeah. Okay, tell me about the Burch procedure and the MMK.
So the Burch procedure, so these are both abdominal procedures, I believe, and they are to suspend the urethra. One of them, they're both retropubic, I thought, but the MMK goes into the actual periosteum, and so you put 2 stitches in at the mid-level of the urethra, and then you anchor them to the periosteum in the posterior side of the pubis bone for the MMK. And then the Burch, you still put 2 stitches on each side, about 2 centimeters from the urethra, and then you anchor them into Cooper's ligament, or the lacunar ligament.
Yeah, Cooper's ligament's about right. Yeah, I would say that. Yeah. Yeah, Cooper's ligament. Yeah, so do you use permanent suture or do you use delayed absorbable for that?
I believe you use permanent suture. Because you don't want it to go away, right?
Yeah, you absolutely use
Proline or
you use a permanent suture. Exactly. So the MMK is an older procedure. These are all retropubic procedures that are done. They have to be done open, and the same as the Burch too. And you have to enter that retropubic space. And the problem with entering that
bleeds a lot.
Yeah, and you have that plexus of Santorini where you can get issues with bleeding in that space there, and that's one of the problems with doing these type of procedures. And also too, I mean, they work pretty well. I got dogs walking all over me. They actually work pretty well, but the problem is that it's such a because it's been taken place by TOT and TVT. I mean, to have an incision and to go, it's a bloody procedure, and all the problems associated with the procedure. They can overcorrect it, and they can have urinary dysfunction, like with any procedure. So
yes.
Again,
the few times I've done it is with like an older gynecologist and urologist, and they were talking about how it's very common. So actually they would place the stitches and then kind of tie a loose knot or like a slip knot on purpose so that it's not too tight, like so that it would give a little bit afterwards. Because when they're laying flat, I think they said, you know, almost always when they are upright in their normal anatomical position, like they would sit like on the toilet, then it's not going to be the same. So
right, right.
kind of
Now,
hard
I
to.
just Googled intrinsic sphincter deficiency just so we could, just some common lay people terms for, and this is what they said online. They said ISD occurs when there is weakness of the urethral sphincter, and we just said that. ISD may be caused by genetics, nerve damage, or prior surgery, and that's a lot of times when we see it, previous surgery. Or neurological disorders. Urinary leakage typically occurs more frequently and in greater volumes in cases of intrinsic sphincter deficiency than in cases of stress urinary incontinence without ISE. The midurethral string is the mainstay of treatment for intrinsic sphincter deficiency. Now they also say here treatment may also include a periurethral bulking agent. The urethral bulking agent is injected at the time of the urethroscopy, and we just talked about that. And it's usually done under anesthesia. It says collagen was used as a bulking agent, but coaptite, which is somebody just texted me, thank you, and Durasphere are newer bulking implants that last longer and maintain durability over time. Coaptite combines with calcium hydroxyapatite particles and a sodium carboxymethylose carrier gel to form a scaffold to promote tissue infiltration. I think that's a little bit further than we need to go. So there's a picture. I just went to this website, and it's austinurogynecology.com, and they have a nice little picture on there showing you, it's very simple. Okay, so oxybutynin. What is oxybutynin used for?
That's for overactive bladder.
Yeah, absolutely. Overactive bladder. Good. Exactly. And now tell me the definition of chronic retention of urine or overflow incontinence.
So if you, so I remember the question. So I think it's anything over 300 retention afterwards. I know 50 is normal because I've seen that question in our thing but I guess I don't remember the exact. I thought normal capacity is about.
Well, normal capacity of the bladder. I mean, when people absolutely need to have to go to the bathroom, it's anywhere between 250 to 300.
Mm-hmm.
But patients with a normal post-void residual should be anything less than 50. Post-op, it should be less than 100. Now, anything between 100 and 300, you got to wonder what's going on here. So if you have a post-void residual that it's actually greater than 300, that confirms that you have a diagnosis of overflow incontinence, right? Overflow incontinence. And what is overflow incontinence? Can you explain that to me?
So it's when there's a deficiency or a defect in the person's ability to sense that the bladder is full or filling.
Good.
And so they don't get a sensation that they then need to empty their bladder. So then you end up getting leakage because the bladder is overdistended, and then it just kind of is a constant dribble out. Like they would have constant just leaking of urine.
Right. And when they do urinate, they just urinate just a little bit. Mm-hmm. And they're just urinating. So they really don't know their bladder is full. Mm-hmm. Okay. So they just urinate just a little bit at a time. So yeah, good. Chronic retention of urine. It's usually caused by conditions such as MS can cause it, or a neurological condition of the spine, or patients with long-standing diabetes can have that. So, okay, good. Number 2.
Oh, I'm sorry. Can you repeat, though? Like, the answer was 100 or 300? Like, anything over 100?
For chronic retention of urine, it's over 300 post-void residual.
Okay, so that is okay to list.
So, but a post-op patient, if she has a hysterectomy, right? And
anything
she says
less than 100 is okay.
There you go. Okay. Good. There you go. That's fine. But a lady in your office that comes and says, I'm having problems urinating, and then you do a post-void residual, anything less than 50 is considered okay. If anything greater than 50 would be abnormal. Okay?
Got it.
Okay, number 2.
Okay, a 48-year-old comes to you with complaints of incomplete emptying. A post-void residual of 50 cc's is found. What is the likely condition? A, interstitial cystitis. B, normal bladder. C, stress incontinence. D, overactive bladder. E, neurogenic bladder. And so we just covered that B. normal bladder.
There you go. Good. And the thing is, I get a lot of residents will say to me, or people that are taking the exam saying, well, I mean, she's got incomplete emptying. What's the problem here? I mean, is it really a normal bladder? Well, overall, the capacity of the bladder is okay, but there could be something irritating her bladder, like she feels like she still has to void. So it could be a urinary tract infection that could cause it. And this lady probably needs a urine analysis, or she needs some kind of voiding diary to see what's going on, you know, to see if there is any other issues. But overall, the capacity is considered a normal bladder. Overactive bladder, they should have a normal post-void residual. A neurogenic bladder is the same thing as chronic retention of urine. Sometimes people call it that. Or neurogenic bladder is also another name for, people call it interchangeably, like overactive bladder too. But when I think of neurogenic bladder, yeah, sometimes I think of also overflow incontinence too, because that's a neurological problem. But hopefully you have the terms, they can interchange the terms to you on the exam. I'll just double check that so I'm not giving you wrong information. Neurogenic bladder, I'm pretty sure is another name for it, is either detrusor dysynergia, I think is another name for it, but I'll double check that. Okay, number 3.
Okay. The Q-tip test for hypermobility of the urethra is positive if it deviates A, less than 30 degrees, B, less than 35 degrees, C, greater than 30 degrees, or D, greater than 35 degrees. And so C is the answer. It's greater than 30 degrees, and it's towards the mons pubis, correct?
Yeah, the Q-tip, what happens is when you do the Q-tip test, and I'll just draw a little picture real quick so you guys know, just in case. Okay, so here's the patient laying down on the table. There's her feet. There's her butt. She's got a nice butt. Okay.
Yeah, I just wanted you to draw the picture. That's what I know.
Okay. Okay. So let's pretend the Q-tip is right. Here's her bladder, right? Okay. So her bladder should really be up here. So you put the Q-tip in like this, and then what happens when she coughs? It should go up this way. It goes up. It goes up. It doesn't go down towards the floor. Okay. Right. this what happens is that this is what your bladder should look like. So what happens is that when they cough, this portion goes up towards the ceiling, and then instead of the Q-tip being normally here, this is where the Q-tip would be. Let me draw another picture. What happens is that the Q-tip goes up this way, and so it goes up towards the ceiling. It goes up. So the angle is going to be greater than 30 degrees. So if that makes sense to you, it's greater than 30 degrees. So that's a positive Q-tip test. I don't know if this is a good picture, but Q-tip goes up, doesn't go down, it goes up.
Right.
Okay, good. Okay. Okay, number 4.
Okay, a 55-year-old with stress incontinence is noted to have a 2-centimeter tender anterior vaginal wall mass. What's the next step to confirm a diagnosis? A, antibiotics, B, Q-tip test, C, cough stress test, D, incision and drainage, E, magnetic resonance imaging. So I'm pretty sure that you need an MRI because you wouldn't want to do it. You want to know if it's a urethra diverticulum or if it is a cyst, because if it was a cyst you can incise it and drain it, but if it's a diverticulum then you have to do a little bit more extensive dissection and you don't want to injure the urethra.
Right, right. So this 2 centimeter next step to, yeah. And so your answer is?
E.
E, good, MR. Okay, now just to go back to the overactive bladder. Detrusor over, let me just read. This is from Comprehensive Gynecology, page 497, chapter 21, 6th edition, Lentz, Lobo, Gershon, or Katz. It used to be called Drogenmuller, but now they call it that. Okay, so detrusor overactivity is a urodynamic observation. It is the result of sudden spontaneous detrusor contraction. It has previously been termed as, number 1, detrusor dyssynergia. Number 2, unstable bladder. And number 3, detrusor overactivity. The term idiopathic detrusor overactivity is used as a urodynamic definition. It says also the term neurogenic detrusor overactivity, that's where I got the neurogenic from. Neurogenic detrusor overactivity is appropriate for a neurological disorder such as patients with Parkinson's disease, MS, spinal cord injury, or other CNS pathologies present. That's when they call it neurogenic detrusor overactivity. So that's just a little thing about overactive bladder. And we call it overactive bladder. That's what they call it on TV. The lady the lady walking around the mall with her bladder. She's holding onto her bladder and it's showing where to go, her to go in the mall. That's overactive bladder. Okay, good. So yeah, this is a urethral diverticulum, and a lot of times when you see these, you can palpate them in the vagina, and if you touch it and push forward, usually you'll get some kind of secretion that'll come out of the urethra. Okay, so that's a urethral diverticulum, and people get that sometimes confused with maybe a Skene's duct cyst or whatever.
Right.
So an MR is a reasonable option to diagnose that. Okay, number 5.
Which of the following is a postoperative complication of a Burch procedure? A cystoscopy, B, a rectocele, C, an interstitial, and D, osteitis pubis, E, vaginal prolapse. So D and E, I think, are out because you're directly holding up the vagina, and the urethra underneath, and then D, it's not placed in the periosteum, so that wouldn't happen. So I would, and you're holding up the vagina, which is, so I wouldn't think you would get a cystoscopy. So I'm between B and C, and I was just going to say rectocele, but I don't.
Actually, it's an enterocele.
Enterocele, okay.
And the reason why is because when you change that angle of the vagina, it makes the top part of the vagina a little bit more susceptible to prolapse. So, and this is what happened. It's usually with overcorrection.
So the cul-de-sac is kind of bigger.
Yeah, well, not that it's bigger. It's that what happens is that it says overcorrection of the urethrovesical angle has been suggested as a cause of these long-term urinary and prolapse complications. So if they overcorrect them, they can get a prolapse, and that's an enterocele formation. That's the kind. They don't get a rectocele. They don't get a cystocele. They get usually an enterocele, and that's the top of the vagina that starts to prolapse.
Okay, got it.
Okay.
Okay.
Yep. That's from the Burch procedure. Let me move this over here for a second. Okay. Okay, number 6.
Okay, which of the following may add to confirm the diagnosis of interstitial cystitis? A trial of pentosan polysulfate, which is Elmeron. B, urine cytology. C, urodynamics. D, cystoscopy with biopsy, and E, urine culture. And I believe, so B, C, and E are out. I think that either D or A would be there, but I would think D is more confirmatory.
Yeah.
So D is my final answer.
Yeah, cystoscopy with biopsy is probably the most reasonable answer with that one. Okay, now tell me about interstitial cystitis. What do you know about it?
That it's a state of inflammation. It's very common when people have, it's the most common diagnosis after people have a hysterectomy for either endometriosis or chronic pelvic pain with an unknown cause. Like a lot of times they end up having interstitial cystitis, and likely that was the cause of their pelvic pain. So it can cause like suprapubic pain, sometimes pain on urination. It's a diagnosis, I believe, of exclusion maybe is clinical, but I think you have to rule out all other causes of pelvic pain first and all other causes of bladder pain as well. So a lot of times they'll come to you having had several urinary tract, like several cystoscopies or treated for urinary tract infections but never found an exact organism or no antibiotic worked, and then they end up having this. And I know that you get is it Hunter's ulcers on
Here you go.
cystoscopy, or you'll see the it reminds me of like the Matrix movie where you see like the falling green lines. So you see like little hemorrhages that are like when you let the pressure out of the bladder on cystoscopy, then you'll start to see like petechial hemorrhages that are just kind of falling down.
It says here, on cystoscopy, the bladder frequently appears normal during filling. But with distension under anesthesia, characteristic petechial hemorrhages resemble glomeruli usually appear. Oozing of blood is often seen. This is from Comprehensive Gynecology. I think Comp Gyn has probably got the easiest chapter on urogyn. I mean, I think this actually is a pretty good book for when it comes to urogyn. So it says glomerulations may be a nonspecific finding because they can be seen in asymptomatic women. The cystoscopic findings is not diagnostic of IC, although it's used to differentiate IC from painful bladder syndrome in some studies. Hunter's ulcers are diagnostic of interstitial cystitis, but infrequently seen in women with bladder pain. So if in a biopsy under anesthesia is taken, ulcers with granulation tissue, mucosal hemorrhage, and monocytic infiltration and mast cells and the lamina propria and detrusor muscle are often seen. That's a little bit more information than we need. So the other thing too, they say that presence of immunoglobulins and complement in the bladder wall and the increase of interleukin-6 level in patients may support this diagnosis. So, and then the other thing is, what is the standard medical therapy for the treatment of interstitial cystitis? Just in case they were to ask it on the exam.
Like medication?
Yeah, well, what do you treat it with?
I mean, you can use Elmaron, but I think you have to have a diagnosis of it before you would treat with pentosan polysulfate. Like, I don't think they just give that normally. A lot of times they will have, is that pyridium? And so the ones that I've seen, like, we usually refer that to urology, but like if with a suspicion of diagnosis, we would refer them, and then they're usually on pentosan polysulfate and pyridium to help with the pain.
Yeah, there's a thing. There's standard medical therapy has included dimethyl sulfoxide, DMSO bladder instillations, often accompanied by heparin. Steroids or local anesthesia. They said DMSO is an anti-inflammatory agent that acts as a bladder anesthetic and relaxes the muscles, causes mast cell inhibition, and may dissolve collagen. It's given as a single treatment followed by heparin therapy for up to 1 year. It says many other drugs have also been instilled, including heparin, lidocaine, oxybutynin, but trials are insufficient to show benefit. They also say a heparin analog called pentosan polysulfate, which you were just mentioning, giving orally 3 times a day with some improvements. So that's the only
What
drug.
is the DMSO? It's dimethyl.
Okay, dimethyl sulfoxide. Okay, dimethyl sulfoxide. Yeah, that's all it is. DMSO. Dimethyl sulfoxide. So that's what DMSO stands for, I guess. So it's a single treatment followed by heparin therapy. And another thing too, they used to use hydrodistension as a diagnostic criteria, but it's no longer, they don't longer do it anymore. They used to do like potassium provocation tests too, is another thing to diagnose it, to see. But I think it's frequently very painful to do that. Did you ever hear of them doing that? procedure?
I actually saw them do it on one of our patients because when I was in residency, we have a urology, like a pretty big urology department. So
Right.
we would consult. They came in and they did that on a patient that we had done a hysterectomy on.
Oh,
And it
really?
looked, yeah, so she was asleep, so she didn't really
Move around much.
notice anything, but they filled her, yeah, they filled her bladder pretty, it was pretty tight, like the wall looked like it was going to burst.
Yeah, it says here, it says potassium, it's the potassium test involves inserting a catheter into the bladder and instilling a saline solution followed by a potassium chloride solution. A positive PST test is noted if increased pain occurs with the potassium solution. And they said the international consultation has inadequate data to recommend. They said that's inadequate anymore to use it for the diagnosis of IC.
Oh, so I've never seen the potassium thing, just the overdistension.
Oh,
Like
the
I've not.
overextension, yeah. They put the potassium, the patient usually has a lot of pain associated with it. So they say women should avoid beverages, a carbonated beverage. Oh boy. Avoid any food that's good. Okay. No acidic, alcoholic, carbonated beverages, spicy foods, coffee, tea, chocolate, tomatoes, vinegar, and artificial sweeteners. They said have been all triggers. Tobacco also should be avoided.
So what can you eat then?
Nothing.
I think those things are
Rice.
like in everything.
Rice.
Rice. Yeah. But not too much salt on the rice. No.
Intrinsic thing hold in urine. Yeah. They said what is an abnormal leak point pressure? I think that is abnormal leak point pressure is greater than 60, or is that? I'll have to look that up again. I can't remember off the top of my head on that one. Okay, we'll go on number 7.
Okay, during cystoscopy, you see multiple bladder contractions. What is the most likely diagnosis? A, urinary tract infection, B, genuine urinary stress incontinence, C, interstitial cystitis, D, urethral syndrome, E, urethral hypermobility. Cystoscopy, bladder, so it wouldn't be urethral system because you're talking about the bladder, so that's going to put D and E out, and it's not mobile. And then I'm going to say the most common would be like a urinary tract infection, but I'm not sure that I remember exactly. And it's not C because they didn't mention anything like what we just talked about, and it's not B, so A.
Yeah. Yeah, I think that's probably the best answer, urinary tract infection. Yep. Okay, good. Exactly. Spelled wrong. To fix that, let me just get rid of that. It's annoying me. Okay. Okay, number 8.
Okay. What is the complication as a result of a Moskowitz coloplasty? A, ureterocele, B, ureteral kinking, C, bowel serosal tear, D, urinary retention, E, interstitial. So ureteral kinking, I believe, is the best answer, but between B and, B is going to be it.
Yeah, ureteral kinking is absolutely.
Yes.
Remember, the Moskowitz is when they do concentric rings.
And close off the...
Yeah, to close off the posterior cul-de-sac. Yeah, there you go. Good. And then there is the Hallband's coloplasty, which sometimes is a little bit different. That's when they do the sutures up and down to close the posterior cul-de-sac. So it's not as, doesn't have as many complications as the Moskowitz does. It has the kinking associated with it. Okay, good. Number 9.
Okay. A 78-year-old woman with a history of TAH presents with a complete vaginal prolapse. What is the best option for her management if she is not sexually active? A, Lafort's procedure, B, colpoclysis, C, sacrospinous fixation, D, abdominal sacrocolpopexy, E, McCall's colpoplexy. So the answer is between A and B, and because she has a uterus, because she does not have a uterus, then you can do a colpoclysis if she's not sexually active. If she had a uterus, then you would do a Lafort's. So the answer is B.
Okay, so so what's the difference between what's a McCall's coloplasty?
Okay, so I just read this because I think that I was used to seeing what one of our attendings did was a modified,
Right.
but so it is essentially taking the uterosacral ligaments. It's used in order to obliterate the cul-de-sac to prevent an interstitial. And so you essentially plicate the uterosacral ligaments, and in between it you pick up the peritoneum and purse string it in so that you when you tie the suture you close off the cul-de-sac. So I mean, it's the best way I can explain it.
Okay. Yeah, exactly. And what it does is it obliterates the cul-de-sac done in a vaginal procedure, and it helps support the vagina, but it's not a procedure done to correct prolapse.
Right.
It's not a procedure done to correct prolapse. So what is the best option for her? If she's not sexually active, of course, it would be to close her vagina. B. Yeah, B. B as in boy. Now, sacrospinous ligament fixation would be good if she wanted to maintain her vagina for coital function. Same thing with an abdominal sacrocolpopexy. Those are also done to maintain coital function. The fourth procedure is if you still have a uterus, and then you're closing.
Right.
So that leak point pressure thing, I'm still looking for that. So whoever texted me about that. Okay, number 10.
Okay, which of the following mesh materials is most commonly used for transvaginal taping procedures? A, Prolene mesh, B, chromic mesh, C, allograft, D, polypropylene mesh, and E, xenograph. So I believe it's polypropylene mesh. That's what I think they're made out of. D.
Yeah, yeah, polypropylene mesh, and that's a most commonly used is polypropylene, and that is a non-absorbable mesh, of course. And that's what we use. Xenograph is doing a different species. Allograft is the same species. You could technically use that. So anyway, somebody looked up something for me. Okay, I'm going to text this out to everybody so you can read it. Thank you. Yeah, I need to hire a librarian to do stuff for me while I'm doing this, so I don't have to multitask.
It takes a lot of multitasking. I'm impressed.
I know I got dogs barking, and it's the same thing with you guys when you're trying to do a webinar at home. You've got family members closing doors and washing dishes and kids crying in the background.
I kick my husband out because he's like a distractor.
Yeah, I know, right? And people they don't understand. They just come in and, oh, well, let's just turn the water on. I mean, come on now already. Yeah. I know people do that to me all the time too. The dogs start to bite, to jump around my leg and stuff. Okay, 11.
Okay, all of the following are potential causes for overflow incontinence except A, diabetes, B, multiple sclerosis, C, severe genital prolapse, D, post-surgical obstruction, E, interstitial cystitis. So I don't think that interstitial cystitis would cause overflow.
Yeah.
But I could be wrong. So E is my best answer.
Yeah, definitely. Interstitial cystitis is right. Good. And we just talked a little bit about overflow incontinence. Okay, number 12.
Okay, the most common complication associated with the Burch procedure is A, retropubic hematoma, B, bladder perforation, C, urinary dysfunction, D, mesh exposure, E, urethral injury. So it's not the retropubic hematoma. Okay, so let me do this. So it can be D because there's no mesh. You could have E, but I don't think that's the most common. Bladder perforation, I don't think that would be very common at all. So you could have urinary dysfunction, meaning like it's overcorrected, and I think that would be a little bit more common than the retropubic hematoma. So I'm going to say C.
C. Yeah, I would agree with you on that. Good. Absolutely. C. Good. And we'll talk a little bit about overcorrection, and that causes an anorexia with this procedure, the Burch. Okay, good. Number 13.
Okay, what is the least likely complication associated with the Burch procedure? A, interstitial, B, osteitis pubis, C, urinary tract infection, D, urine retention, E, retropubic hematoma. So B, because it's not in the periosteum of the pubis, so you can't really get osteitis pubis.
There you go. Good. That's that. I think she spells that wrong. Yeah. Osteitis. I think I spelled better. Does that look right? That it's spelled right to you? Osteitis? I'll have to Google it.
I can Google it. Yeah. I was
Osteitis.
thinking because
I don't know. I'll Google it. That's why I have it. That's why I have it typed on my other exam, but I'll have to look at it up. Okay, 14.
Okay, a 54-year-old presents with a history of recurrent spontaneous leakage of urine. Her post-void residual is 300. What is the next best step? A, oxybutynin, B, timed voiding, C, self-catheterization, D, Q-tip test, or E, retropubic urethropexy. So she needs to do intermittent self-catheterization, or timed self-catheterization, like every 4 hours or whatever. She can't really do B because she wouldn't know if her bladder is full, right? So C.
Yeah, absolutely. Self-catheterization. You got it. Good. Good. Excellent. So, yeah, self-catheterization. So the only way they know that their bladder is full, they don't know, actually. So you have to straight cath them and empty their bladders for them. It's a neurological problem.
So I think it is with the E, the osteitis, because
Okay.
I just typed it in my text thing and that's what it came up.
Okay, let me go back and fix it. There we go. Wait a minute, that's not it. Okay, here we go.
But it does look
It looks funny. It looked funky
Yeah.
for a minute. It didn't look right to me. Okay, good. So oxybutynin again. Timed voiding is a good something for patients who have detrusor dysynergia. They can, or overactive bladder, timed voiding. I mean, even people with stress urinary incontinence, you could do timed voiding with them too. So their bladder's always empty, or know when they're to empty their bladder. I think that's probably a reasonable thing. Okay, next question. Number 15.
Okay, a short-term complication of trans obturator tape are all of the following except A, mesh erosion, B, urinary tract infection, C, urge incontinence, D, voiding dysfunction, and E, urinary retention. So I don't think you would get urge incontinence. So C?
And
I could be wrong on that one, but C, it seems like it would.
yeah, short-term, all of the following. Well, mesh erosion is not a short-term complication, is it?
Oh, yeah. Well, why would you get, urge from, unless it was because of the urinary tract infection? I don't.
Well, I mean, they could have, the TOT could have they could have urinary dysfunction, and mesh erosion definitely will not happen short term.
Right, it's not going to be right away.
That's not going to be a short-term problem. So I think that all the other ones are more likely than a mesh erosion, even though urge incontinence is probably at the lower part of the list.
Okay.
You're
Yeah, I
unlikely
didn't
to see that.
I wasn't thinking. I didn't read the short-term part. I read it, but I wasn't paying attention to it.
Yeah, and let's see what I have here down here. It says long-term complications may be associated with supporting mesh and mesh erosion. Okay, so major risks of the procedure in general are urge incontinence, voiding dysfunction, urinary retention, failure to correct the stress incontinence, groin pain appears to be another potential postoperative problem. Long-term complications associated with the supporting mesh include mesh erosion. So, all right, number 16.
Okay, on pelvic examination, you notice a right lateral anterior wall vaginal, a right lateral anterior vaginal wall defect. This defect is most likely caused by A, defect in the pubococcygeus muscle, B, detachment of the endopelvic fascia from the ischial spine, C, detachment of the endopelvic fascia from the pericervical ring, D, detachment of the pubocervical fascia from the arcus tendinous pelvic fascia, and E, disruption of the pubourethral ligaments.
Yeah.
So sorry. I
That's
think
right.
that was my husband going home. So, so lateral anterior wall defect. Hang on. I'm so sorry. They're at the door.
Okay.
So I saw the answer was D, but I don't think I got that right. So lateral anterior wall vaginal defect.
Yeah, well, see, it's a right lateral anterior vaginal wall defect. It's not in the midline. So
Okay.
if it's not a midline defect would be a disrupting of the pubocervical fascia in the midline. Now,
Okay.
if this is a defect to the side, it's because the fascia has come off the arcuus tendinous fascia. It's separated on the side. So that's called a paravaginal defect.
Right.
Defect. So that's, if you Google it, you can see a better picture of it, or even YouTube it, and you can see actually an exam, and they show you what a paravaginal defect looks like if you've never seen one before. It doesn't hurt to just use
Right. So I know the paravaginal wall. I guess what I was saying, how do you know it's the pubocervical fascia?
because that's the
Lateral
that's the fascia that's in the midline there in the part of the vagina. That's the fascia that attaches to hold up your bladder. That's your pubocervical fascia. That's the fascia that's separated too when you do your vag his. That's what you're getting into. Okay.
to right lateral anterior. I guess I just need to visualize it for a second, but I was like interrupted in my visualization.
I know, with your dog's barking. I'm sorry.
Okay, so I got it now.
Okay, 17.
Okay, a 59-year-old woman complains of frequency nocturia and spontaneous leakage of a large amount of fluid. The most likely etiology is frequency nocturia and spontaneous leakage. Stress urinary incontinence, chronic retention of urine, vesicovaginal fistula, mediation side effect, or do you mean medication side effect? And detrusor dyssynergia. So frequency nocturia. So it's not going to be A because stress urinary incontinence, they wouldn't have that at night. Chronic retention of urine, I don't think so. Vesicovaginal fistula, no. So detrusor dyssynergia, E. And D, did you mean that to be medication side effect?
Well,
I think the answer is E, but I'm saying
medication, not mediation, medication.
Yeah. So my answer is E.
Yeah. Your answer is detrusor dyssynergia?
I think so. Or B.
Or B. Okay.
E or B. Because I don't think she would have would she have really getting up to go to, I guess so, so B.
Well, see, they have nocturia with stress urinary,
I thought they didn't have that because they wouldn't be they wouldn't be valsalvaing
right,
at
so
night,
stress urinary
right?
incontinence, right, you're right. Nocturia doesn't happen at night. Chronic retention of urine, they don't leak a large amount, they only leak a tiny bit, right?
And so, right. And so detrusor dyssynergia would be the only one because they're having involuntary contractions, and so then they would squeeze out a lot of.
Good, excellent. You got it, right. And vesicular vaginal fistula would be leaking all the time, or they would always be wet.
Right.
Okay, good. Okay, number 18.
Okay, after a radical hysterectomy, a patient develops a uretero-vaginal fistula. What is the next step? So A, stent placement. B, ureter anastomosis, ureteroneocystotomy, and D, urethral reconstruction. I'm sorry, E, cystoscopy. So a uretero-vaginal fistula. So first you have to do a cystoscopy and place the stent. So like I think we talked about this question before. So ultimately you're going to place stents before you would correct it, because you got to take the urine away from the vagina. Like you don't want it to just be leaking in the pelvis.
Right.
So,
So
you would place stents.
Good. There you go. So you're absolutely right. You want to get a stent in there so that urine doesn't go through that fistulous tract anymore, and then the urine will be deviated through the stent, and then the fistulous tract will
But don't
close.
you have to do a cystoscopy to place the stent?
Yeah,
Like,
absolutely.
wasn't somebody like that was controversial because you're like, which one is the immediate next step?
Well, maybe
I think
okay.
I remember.
So what is the first step? Yeah, if she has a uretero-vaginal, the first step would be to probably do a cysto and then place
to confirm
the
the
stent.
diagnosis, but
Yeah,
you
but
know
but
she
they're
has
saying
the fistula.
Yeah, they're saying after the patient develops a fistula, they're saying that she has one. So I'm assuming that the workup is done. I think that the better answer here should be what is the next step in treatment, or the next step, or I don't know how to make it so it doesn't, so you wouldn't pick cystoscopy first, because I'm assuming
I
that
think
you would have done a cystoscopy already, or you would have, yeah, I mean, if you're...
And that's what I put. I think that you just, like, if you read the question carefully, I mean, it makes sense because they're saying they have the diagnosis of that instead of how would you diagnose it, or how would you, like, identify it, you know?
Best. I'm trying to see how I can reword it, make it so it's not the next. I like that next step because I use that a lot in the prologues. Next this, next that, next best management.
I think it's
this.
good. I think it's good. I just remember talking about it when we had
Right. And I agree with you. I think I remember somebody mentioning that too. Okay. Wait, number 19.
Okay, in most ambulatory women with incontinence symptoms, which bladder test is sufficient to diagnose stress incontinence? A cotton swab test, B, a cough stress test, C, post-void residual test, or post-void residual, urethral pressure profilometry, E, Valsalva leak point pressure. So B, the cough stress test.
Yeah, there you go. Cough stress test. Good. Cotton swab test is for urethral hypermobility. Post-void residuals for chronic retention of urine. Urethral pressure profilometry and Valsalva leak point pressure are two measurements that are used as part of the
Systometrics, right?
Well, your multi-channel urodynamics.
Urodynamics, right.
Right. So your Valsalva leak point pressure, for intrinsic leakage is seen when a pressure is less than 60, and then your urethral pressure profilometry is performed. Maximal urethral closure pressure is determined by averaging 3 profiles. This makes a diagnosis of ISD. So it's one of your measurements as part of the multi-channel, your urethra and Valsalva leak point pressure. So they're the ones that you look at when you're evaluating for intrinsic sphincter deficiency. Okay, number 20.
Okay. A 39-year-old woman with a 6-year history of urinary frequency, urgency, and dysuria. She had 5 negative urine cultures. Cystoscopy showed a normal bladder and a reddened urethra. The most likely diagnosis is A, genital herpes, B, urethral gonorrhea, C, urethral syndrome, D, vulvar vestibulitis, and E, urinary tract infection. So C, urethral syndrome, because the urethra is red.
There you go. Good. And that's the only reasonable answer there. Good. C, urethral syndrome. Because the negative urine cultures, and the key is this red in urethra. So that's the only thing it really could be. Okay, number 21.
Okay, which is the best initial test for the diagnosis of neurogenic bladder? A urine culture, B, a post-void residual, C, voiding cystogram, D, urinalysis, and E, urodynamic testing, which is the best initial test. So C, avoiding cystogram.
Yeah, that's what I would pick. Oh, they said the post-void residual. Oh, that's right, urogenic bladder.
Because they would be chronic, they would have chronic residual or chronic overflow, I guess.
Yeah, there you go.
So first before, gotcha.
Yeah, you want to do post-void residual. I think for detrusor or dyssynergia, I think avoiding cystogram or even a cystometrogram would be a more reasonable test than, yeah, you always want to do post-void residual. Good.
Okay.
Okay, number 22.
Okay, a 60-year-old woman
Oh,
complains
wait,
of frequency.
didn't we do this one?
We did, yes.
Okay, I'm going backwards. Okay, number 23.
Okay, which urogynecological procedure will be most likely to cause a ureteral injury? A, an anterior colporrhaphy, B, a Burch procedure, C, an MMK, D, a perivaginal repair, and E, a sling. So a ureteral. So probably the anterior colporrhaphy, just because, well, or the, okay, hang on. So it's not going to be E. It's not going to be the MMK because you're looking right at it. And it's not going to be the Burch because you're looking right at it. So you can't, I mean, and I think that it's not so close to where the ureter would come in. So it's either A or D. And I'm pretty sure it would be A.
Let's see.
Not completely wrong.
Let's see here. Ureteral injury. I see a sling wouldn't. MMK Burch, no.
Yeah. So I'm between A and D, but I think that you'd have more of a chance. Well,
yeah, I think a perivaginal repair, if you're digging on the side there, it'd be more likely to get a ureteral injury.
Okay.
Yeah,
Okay.
anterior colporrhaphy, you're in the midline there. So, yeah, perivaginal, you're starting to muck around on the sides, and you're likely you could get the ureters. Okay, good. Okay, number 24.
Okay, a woman undergoing cystoscopy has a petechial hemorrhage and bleeding is noted in the lining of the bladder. This is most consistent with A, acute cystitis, B, chronic urethritis, C, interstitial cystitis, D, urogenital atrophy, and E, detrusor instability. So it's most consistent with C, cystitis, or interstitial cystitis.
Yeah, I think you're right. We just kind of talked about that too, right?
Mm-hmm.
Yeah, and that's your Hunter's ulcers with neovascularity. We'll just talk a little bit about interstitial cystitis. Okay, number 25.
Which of the following procedures has the highest failure rate for vaginal prolapse repair? A, abdominal sacrocolpopexy, B, uterosacral ligament suspension, C, sacrospinous ligament suspension, or D, colpoclysis. So the best one is A, so it's not that. And colpoclysis is pretty darn good as long as you're not going to be having any sex. I want to say that it's the sacrospinous ligament suspension because then you attach the vaginal cuff to one side.
Mm-hmm.
You know, it's either B or C, and now that I talk about it, maybe it's B.
Yeah.
It's B. Okay. Because the ligaments, it would be hard to get them in the right. I think it's B. It's my final answer.
Okay, let's see if you're right. Actually, it's C.
And I should have gone with my first. I knew that.
See? Well, no, okay, there you go.
Oh, my God.
See, that goes to show you. You guys talk yourselves out of the right answer. You usually do that, and that's common. That you said, I'm going to pick C, but I know the answer is probably going to be B. I mean, why do you guys do that? Don't do that.
Yeah. Okay, hitting myself on the head. Right.
I know. If you see yourself doing that on the exam, well, I'm going to pick
your
C.
First answer.
I'm going to pick C, but I know the answer is B, but I'm going to pick C anyway. Don't do that.
Okay.
because you know the answer you initially picked was right. See,
Right.
when you start to second guess yourself, that's when you screw up, and that's when you pick the wrong answer. So be careful of doing that. I mean, don't you guys? You believe it or not, you're a lot smarter than you really think you are, and I think you got to have some confidence because you guys really know the answers to all these. Okay, number 26. We've done this all year long. Number 26.
Okay. Patients with interstitial cystitis will exhibit any or all of the following except A, frequent urination, B, bladder pain without evidence of infection, C, vaginal wall tenderness on exam, D, erythema of the urethral meatus, E, suprapubic tenderness. So, of course, you have E. Of course, you have A, B, and you do have C. I don't know if the urethral meatus is going to be evident. So I'm going to say I don't think they have D.
Okay.
Because that's like just the opening outside.
Okay, so I listen. This part of the exam I haven't seen in a long time, so I'm doing it with you.
So I think it's D because they can have frequent urination because of irritation.
Yeah.
They can certainly have bladder pain and they don't have evidence of infection. When you do the exam, if you press up on where their bladder is,
right,
then they're going to have tenderness. But I don't think the urethra is going to be red. That's like with the the urethral syndrome. And of course they're going to have suprapubic. So D is my answer.
There you go. D, and you're absolutely right. Good job. See, we just talked about that. Okay, number 27. We just talked about this too, so you better not get this wrong.
Oh gosh, no pressure, no. Elmaron is structurally related to which of the following drugs?
And I just
A,
read this to
heparin,
you.
yes, B, naproxen, D, diphenhydramine, C, diphenhydramine, D, cromolyn sodium, and E, oxybutynin. So A, heparin is the answer.
Good. See, by just me reading that little tiny thing to you, see how you learn that?
Yes.
Isn't that pretty cool? I mean, just like me reading. See, that's why that damn camp is just so important. The camp is just so, because what happens is we all read to one another and we just remember stuff. I mean, the more you read, the more you remember. And to go through this huge camp file in 2.5 days where we go through every topic and then we discuss it. Then, I mean, it's kind of like sitting there all day and studying. That's all you're doing is sitting there all day and studying. And then we get done early. We get done like about 3:30, 4 o'clock. And what's nice about it is I know in Chicago, I know for a fact, I think I'm personally going to be doing a breakout session on, I think the second night, I'm going to do a breakout session where we're going to just go over all the topics that are like urogyn and primary amenorrhea, and I'm going to have like a little syllabus, and I'm going to go over all the most common crazy asking topics that they ask about on the exam. So I may have a little breakout pizza party on from like 7 to 9 o'clock or something. We'll have pizza delivered or something. That sounds like fun, right? Are you coming to Chicago?
I'm not coming to Chicago though.
Which one are you coming to?
Well, so I actually last minute signed up to go tomorrow, so I'll be in Key West.
Oh, you're coming to Key West.
Mm-hmm.
Oh, okay. Well, we're going to do a little breakout session then too. We will probably do one. I think
we can have a pizza party or
we
a
can
Thai
have a pizza
food
party
like
again.
No.
We'll buy pizza and we'll have a little pizza party. I have that room the whole day anyway. So she's I told her we may use it at night from like 6 to 9 or something, and she said, "Oh, that's fine." So we'll have a pizza party Saturday night or something.
Yeah,
okay.
Sounds fun.
Okay, good. Okay, number 28.
Okay, cystometry differs from complex urodynamic testing in that A, it is assessed only the filling. It assesses only the filling phase of micturition. B, it does not require urethral catheterization. C, measurement of residual volume is not required. D, it can be performed in the office. And so I believe, is it D, that it can be performed in the office?
Okay.
Because we don't usually do urodynamic testing, but we do cystometry.
Yeah, you know, it actually
it's A.
Yeah, it's A. Yeah.
Okay.
Yeah. So The cystometry and urodynamic studies require catheterization. Measurement of residual volume is always the first step in bladder function evaluation. Both systems can be performed in the office. That was her thing there. So yeah, it assesses the filling phase of micturition. That's why cystometry is good for when you're evaluating somebody with urgent continence. Cystometry. Okay, good. Number 29.
Okay, the Bonney test performed in the office can be used to evaluate A, stress incontinence, B, elevated post-void residual, C, cystoscopy, and D, paravaginal defects. And I do not remember the eponym Bonney, but so I'm gonna the Bonney test. I think it's C, cystoscopy, but I think it's C.
Yeah, it is. It's used to evaluate in the office actually stress incontinence.
Stress. Okay.
Yeah,
Is it
actually
different
does.
from the cough test?
Well, what it is that you do a cough stress test on somebody, and then what you do is you put your fingers or a Kelly cap underneath the urethra and push up towards the ceiling, and if to tell the patient to cough again. And if she coughs and the urine doesn't come out, then she'll probably work well with the sling. So that's the answer to that one, and that's going to be A, stress incontinence.
Okay, I got to end on a good note.
Yeah.
I just didn't, I remember reading it, but I guess I didn't remember the name of it.
Yeah, I'm going to I'll go to 10:30 tonight, and then I'll email this test out to everybody so you can go through it again, okay, with the explanations.
Perfect.
Okay, number 30.
Okay, a patient is placed in dorsal lithotomy position and 250 cc's of sterile water is instilled in the bladder. The catheter is removed and the patient is asked to cough. A few seconds after her cough, urine spurts from the urethral meatus. The diagnosis is A, neurogenic bladder, B, stress incontinence, C, primary urethral sphincter deficiency, or D, overactive bladder. So because there's a delayed urine spurt, I think it's D, overactive bladder. Because if it was stress, it would be when she coughed, it would come out.
Yeah.
Right?
Yeah. So let's see if you're right. Overactive bladder. Okay. So a few seconds.
That's a short delay, though.
Yeah, a few seconds after her cough, then she loses urine. So remember, the bladder after the Valsalva, then there's the contraction, and then they lose urine.
Mm-hmm.
Yep. Okay, good. Okay. Number 31.
Okay, a normal post-void residual as measured within 15 minutes of a voided volume of at least 150 cc's is A, 20 cc's, B, 50 cc's, C, 100 cc's, D, none of the above. And we already talked about B, 50 cc's is normal for a normal patient.
Volume, let me see. A normal post-void residual as measured within 15 minutes of a voided volume of at least 150 cc is...
B.
Yeah, I think B would be the right. Like I said, I haven't seen this test in a long time. Let's hope we're not wrong.
I hope
Yeah, there you go.
Yeah.
Good. Excellent. Good. B. Okay, number 32.
Okay, first urge to void usually occurs at the bladder volume of A, 50 cc's, B, 100 cc's, C, 150 cc's, and D, 300 cc's. So we talked about this too, and it's between 250 and 300 cc's. Although it does say first urge.
First urge to void.
So it could be C.
Yeah. See, this is like you're walking around the mall and it's like, I think I just drank that big soda.
I think it might go to, yeah, so I think C, yeah.
There you go. Good. Okay, 33.
And then D is when you say get out of my way.
Yeah.
Okay, 33. A normal functional capacity of the bladder is A, 300 cc's, B, 500 cc's, C, 800 cc's, and D, 1,000 cc's. So I believe the answer is it's clearly either B or C unless you're like a surgeon and then it's D. But I think it's B, 500 is like the average.
Normal functional. Well, that's pretty high, but let's see if you're right.
You think?
I don't know. I would say 300,
That
but
could
maybe you're
be.
right. I
Oh,
thought it
you're
was
right.
300.
300.
What is the most urine you have ever straight cathed from somebody?
I think probably like a liter.
You've seen a
I think
liter?
someone said, yeah, but not much more than that. And it was probably like 900 something,
Yeah,
really,
the
but
most I've ever
pretty
seen
darn
was
close to
the
is a
most I've ever
liter.
seen was 800. It's a lot. And then I was at the course this weekend, and somebody said, "Oh, I've seen 4 liters." I'm like, I think you're on.
What?
I think that was a paracentesis from a probably.
Now, like I have heard of a patient being in the ER and then, one of my colleagues went down to evaluate them because they thought there was something and their bladder was about to rupture is what they said because it was, but I don't know what the volume was that they took out of it.
Oh wow, that's crazy.
Yeah. So I
Okay.
guess the CT didn't work.
Yeah.
And, all of the following are indications for urodynamic testing except for A, a failed conservative therapy, B, a patient has voiding complaints, C, complicated medical history, and D, none of the above. All of the following are indications for urodynamic. So failed conservative therapy would
Yeah.
definitely be. Has voiding complaints. Okay, complicated medical history. What do they mean, like complicated, like urine history, like mixed
Yeah.
incontinence?
Could be. Could be like neurological
I,
problems or whatever.
I mean, like, I guess I'm a little, you could say B, but I think D, because if they have voiding complaints, you would want to do some other workup before you would do the urodynamic testing, right? Like
Yeah. I mean,
cystometrics.
yeah, I
I don't
wouldn't
think you
think
would
so.
go straight to urodynamic testing from that. So,
Oh, she said D, none of the above.
yeah. Prior incontinence
Continence surgery, uncertain diagnosis is a reason to do it. That's what she said anyway. I guess
Okay.
I guess failed conservative therapy wouldn't be a reason to. I mean, oh, okay, so
Well, it's saying
stop
all of
drinking that
them are.
caffeine.
Well, it says all the following except, so they're saying that all of them are reasons, right?
Um, failed.
So if
Well, she
somebody
said
comes
none of
in,
the above. None of the above are actually indications. None of the above. So the answer is D. It's a crazy worded question. It shouldn't be like that.
what? Okay, I guess I misread that because I didn't, I was
Yeah, none
thinking
of the
the other
above.
things are except.
Yeah. Um,
Are you sure? Because, okay, so I'm saying, like, she's saying all of the following are indications for it. So saying
except.
except, and so none of them are accepted. So that means
Yeah.
all of them would be, right?
So, well, none of them are accepted, but I don't think none of them are indications for urodynamic testing. Like if somebody comes, I think that's what she was trying to say. I think I have to reword this question. I think it's a little confusing.
Really?
It doesn't
Yeah.
really. Let me
So
see if
that's
this
not,
texted
so
me.
failed conservative therapy is not a reason for it?
Yeah, and somebody even texted me. It's not clearly worded. None of them are indications. Okay, so all the
Okay.
following are indications except. And you know what I would do is I would just put something else there. Or which of the following is an indication for urodynamic testing, and I'll put prior incontinence surgery. I can put that here. Prior.
No, but so then they're saying that one is an uncertain diagnosis.
Well, I'm going to change the question. All the following. Which of the following is an indication?
I guess from that, I'm thinking that she thinks failed conservative therapy is an indication, though. Because if you just plugged in another like dummy answer instead of the none of the above, then
Right.
it would be saying all of these A, B, and C are indications except,
Let me get
right?
Droga page 545, and let me see if it's in there. Let me pull it out.
That's the same as comp gyne.
Yeah, let me see. Yeah, I
Right?
have it.
Okay.
This is the green one. I have it. Because the green one's the old one. The red one's the new one. 545.
Yeah, I don't think I like the new one,
You
actually.
don't like it? Okay. Sure.
I like the old one.
540. Here she is. 540. Oh, here we go. Uretero-vaginal. Oh, okay. Cystometry is not always necessary for beginning conservative treatment program for stress, urge, mixed incontinence, or symptom. However, if the diagnosis is unclear, the patient has failed conservative therapy, has had prior incontinence surgery, has voiding complaints, or has complicated medical history such as neurological bleed, then urodynamic testing is indicated. Okay, well, maybe she had the question. It's just worded. It's all worded right.
It is very weird the way it was worded.
Okay, cystostomy is not always, okay, so, however, the neurodynamic testing is indicated. So it's indicated if your diagnosis is unclear, the patient has failed conservative therapy, has had prior incontinence surgery, has voiding complaints, or has a medical history such as a neurological disease.
Mm-hmm.
So
it's right, technically. It's just really weird the way
just
it
weird
was
the way
written.
it's worded, right? So I understand what you mean by that. It seems like that none of these would be right, but they are actually. Somebody just sent me another text message here. Let's see what they said here. Option D cannot be none of the above. Okay, except, well, why don't I just put a different question here?
It could be none of the above, or it could be all of the above are indications.
Yeah, let me see. Complicated medical history, failed conservative therapy, patient has voiding complaints. Okay, is that a reason
There you go. Yes. Then you know that that's not it.
Do you like that better? Okay, somebody
I
said
like it.
that's better. Okay, there you
Yes.
go. All right, 35.
Okay, on a midstream clean catch specimen, what number of any specific microbe is indicative of infection? 10 to the third power, 10 to the fifth power, 10 to the sixth power, or 100? So I think it's 100,000, which would be 10 to the sixth power, right?
Okay, let's see if you're right. Oops. Yep.
10 to the fifth power is
Yep.
100,000. Sorry,
Yeah.
it's my
Sixth power
math.
be a million.
My scientific expression or whatever.
That's okay.
So
Okay.
yes, I got.
Well, it's getting late. I'm going to stop here. I'm going to email you guys out the remainder of the exam so you can go through it on your own. I'll send it out with the explanations and everything. I don't want to go way over tonight, but I just want to thank you guys for all being here. And listen, we had a really good year for all the people that were here this year and who hung in there the whole year since October. We started October 21st. And we've been going the whole year. I mean, we've probably been going on and off for about 7 months. So you all should give yourselves a hand for working as hard as you have, and I will keep in touch with you. Feel free to send me an email, text message. I'm going to be posting stuff on Facebook every once in a while. I did recently post on Facebook all the committee opinions and practice bulletins that I feel are the most important and have the highest yield when it comes to studying for the exam. Of course, I probably don't have every single perfect one, but they're all up on Facebook. My friend Sophie, she posted that for me today. And if I come across some interesting facts, I'll post them on Facebook, so keep track of our Facebook page. And I think that's the best way to communicate with everybody. And of course, if you have a question about something and or you have a tip or something, just post it on Facebook. I mean, everybody would probably like to hear your tip or what you're doing to study. And again, we're having a must-pass camp this weekend, and I'm looking forward to Dr. Heiss being there. We're going to have a pizza party Saturday night probably. We'll probably do the same thing in Chicago and in Newark. So if you're interested in coming to the camp and you are strapped for finances, make sure you just send me. I've worked with a bunch of people today who are really strapped, and they're practically coming for almost a voluntary kind of thing. So, but they're helping me out though. And if you have any issues where you want to talk to me, feel free to give me a call or a text or an email or whatever, or you can Facebook me or whatever you want to do. The OBGYN board prep is on our Facebook page. So don't forget to follow us. And then I'll see you guys all at the camp. I'll be sending out emails, giving you words of wisdom. And don't remember, when you take the exam, the correct answer is right in front of you. It is right in front of you. Don't flip out. You've got I think it's 220 minutes to take the exam. So, and the exam, I think it's 225 minutes to take the exam, and the exam is only 220 questions. So you will get through it, and you have enough time. So good luck, guys. Take care. It was great having you here all year, and for all the new people that were here since Atlanta, thank you for joining in on our webinar. We really enjoyed having you, and thank you for all my readers. You guys did a great job this year, and I appreciate it. See you, and take care. Have a good night, and hopefully I'll see you guys for the oral. Take care. Good night.